Dear Chairman, dear colleagues, it's a real great pleasure and honor to be part with you, and in the next minutes we are going to present the data having to do with the transcatheter closure of paramitral defects. So, opposed to para-aortic defects, the mitral valve paravalvular leaks are more common, more symptomatic, larger, and often repair is more complex, and most frequently located between the anterior lateral and the posterior medial aspect of the mitral valve. In 80 to 85% of the cases, they are oval or crescent in shape, having irregular borders. And regarding the pathogenesis, there are several factors favoring the development of such defects, such as annular calcification, endocarditis, active or prior, the corticosteroid treatment, of course, several technical considerations having to do with the surgery, and almost 75% of the cases occur relatively early in the first year post-operation, associated mostly with the technical considerations. Regarding the clinical presentation, most of them occur asymptomatic, having a benign clinical course. However, less than 5% of the cases, they can have or they can lead to severe clinical consequences, such as congestive heart failure or symptomatic hemolysis that can be occurring in 40% of the cases, mainly with mechanical valves and smaller defects, and always we have to be suspicious about the endocarditis. This is a fantastic graphic coming from Garcia showing the different hemodynamic patterns related with hemolysis, and just to mention the fragmentation, the collision, and the acceleration. Of course, repair is the gold standard management approach in patients with severe symptomatic defects. And of course, surgery is maybe the first approach, especially when endocarditis is combined or when there is mechanical instability of the prosthesis. However, reoperation is associated with high, more than 10 to 50% mortality and up to 30% recurrency. This is a very nice observational study coming from Mayo Clinic showing similar recurrency regarding the reintervention rate between percutaneous and surgical approach. And based on meta-analysis and of several observational studies, the long-term results regarding mortality and MACE are similar between surgical and transcutaneous approach. Very recently, a few weeks ago, we have the data coming from the KISS registry, almost 350 cases, which showed the early benefit of transcutaneous approach regarding mortality and complications in the comparable long-term results. So based on that, guidelines from both sides of the ocean suggest as Class 2A recommendation the PVL occlusion in mitral position based on percutaneous approach when these procedures done in comprehensive centers with a high experience, when the surgically risk it is very high or prohibitive, and of course when there are favorable anatomical characteristics. Limitations to proceed through percutaneous approach to close such defects is the high severe instability of the prosthesis, the so-called rocking valve, the presence of thrombus, the active endocarditis, and of course when another operation must be done. When we want to evaluate, gold standard approach is the echocardiography, and especially the transesophageal echocardiography. By using the QLab and 3T analysis, we can estimate the severity, we can define the location, the size, shape, and orientation, having always in mind the dropout phenomenon. And when we want to go one step further, we have to proceed with ECG-gated CT analysis using 3D and 4D reconstructions, and which can define better the anatomy and the morphology of these defects, and also providing information regarding the optimal crossing angle. Imaging is also important during procedure. Transesophageal echocardiography gives us important information for the precise deployment and implantation of the devices in order to estimate the correct function of the prosthetic valve, and of course to estimate the residual degree of paravalvular leak, and of course by using different fluoroscopy projections like the left projections, which can show us the mitral valve and phase, so we can better confirm the correct widening through smaller leaks, or the right projections, which are very helpful during implantation process. Fusion techniques can also be used. They can give us, provide us dynamic information during the procedure for the better and the correct wiring and implantation of the devices. And regarding across which is the access site, in case of the paramitral defects, we have always to think first the integrated approach through the septum. In such cases, we have to follow the rules that we follow for the TR procedure, so we have to go posterior and slightly superior in order to have more space inside the left atrium. As an alternative, and especially in posterior and septal-oriented defects, we have to use, or we can use the retrograde transapical approach, which gives us direct and easy access. And no more, we don't use further the retrograde approach through the femoral artery due to the electrical and hemodynamic instability. Of course, when further support is needed, we can use the different loop techniques. And regarding the device that we can use, of course, up to now, there is no dedicated device. Most of these devices made from nitinol. In the early years, we used the ASD and the VSD devices, and lately we use more often the AVP2 for round-shaped defects, or the AVP3, which is better adapted for crescent and shaped defects. The AVP3 has CE marked approved in Europe, not at the moment FDA approval. However, we expect the data from the paradigm study, which is going to give us new insights regarding the AVP3 in such defects. Up to now in Europe, the only dedicated device is the Occlutech. It has CE mark since 2014. It comes in two different geometries, square and rectangular. The latter one is the more often used, up to 70% of the cases. It has a secure mechanism, and of course it is available in different sizes. And based on that, we can decide which type of device we have to implant and with which way, based on the size, if it is small or large, based on the shape, if it is oval, crescent, or based on the complexity. In case of complex anatomies, very large anatomies, or anatomies with boundaries which prevent the full expansion of the device, we can go with simultaneous or sequence deployment technique. And this is a very interesting technique, very recently published in JACC intervention, coming from memory, 40 cases for both para-aortic and paramitral defects, showing this interesting sequential deployment of a covered stent initially and thereafter a vascular blag. The technical success was 100%. There was no in-hospital complication or post-procedural hemolysis. Of course, although costly and expensive, the 3D printing models can be used, especially in complex morphologies, and always during procedures we have to be aware about issues regarding the resistance and the friction in advancing our devices by using different tips and tricks like stiffer wires or smaller hydrophilic catheters if that's possible, and the so-called span cans. By pushing and pulling technique, we can overcome such restrictions. Regarding the complications, we have always to be aware about the interference of the device with a prosthetic valve that can lead in sudden hemodynamic deterioration, and of course the embolization of the occluded device, which more often occurs early during the procedure. However, late medications can extremely occur. Hemolysis is another complication that can be seen during the follow-up of our procedures, and these can be seen mainly after not totally occluded defects, in partially occluded defect, in severe calcified cases, and of course more often in mechanical valves. In such cases, the first approach is to wait, hoping that the epithelialization of the occluder device and the development of the fibrosis is going to close these defects, diminishing the disruption of the red blood cells. And this is the first publication in chest in 1975 showing the spontaneous closure of paravalvular click. This is the first publication in 92 in JACC coming from Hurricane for percutaneous approach for para-aortic defects, and the first publication for paramitral defects done by Pate in 2001 with a small series of cases Since then, there are several publications from a small series and observational studies showing a satisfactory high technical success rates, more than 80 to 85% of the cases. 3 years ago, we published the Greek data, almost 40 cases for both para-aortic and paramitral defects, showing very high technical success up to 90-95%, and by using the AVP3 device as the most commonly used device. Data coming from the Occlutech showing that the rectangular in-shape device is the most common in use, up to 70% of the cases, and that the device, procedural and clinical success were most of the cases 90%. And of course, regarding the predictors, we have always to think the type of the device and the experience of the center. These are data coming from Spain, from the whole registry, versus opposed to the para-aortic defects, where the size is the only independent predictor for procedural success. Based on that, there are several algorithms proposed showing that in symptomatic, severely symptomatic paramitral defects, especially when endocarditis or instability of the prosthetic valve exists, we have to think first the reduced surgery. In all other cases, we have to think the percutaneous approach, and by that, I want to conclude by saying that the paramitral defects are relatively rare. There are less than 40 cases per year in our country. Imaging is of meticulous importance. Procedure can be challenging, however, success rate is very high. In case of hemolytic anemia, we have to target the complete resolution of the defect, and of course, based on the recently published guidelines, decision of whether we can proceed with transcatheter or percutaneous or surgical approach depends on the risk status of the patient, the anatomical and morphological characteristics of the defect, and of course, the expertise of the center. And with that, I want to thank you for your attention.
Thank you, Dr. Chalapas. I will give you a final message that it's fortunately a rather rare condition, but the percutaneous treatment is building up. Professor Voronikis, any experience in Greece with
yes. I think we have the most, I would say, experience. A few centers are doing the procedure. This is an excellent presentation, but we have to admit that this is a very, I would say, difficult in a way that you cannot have certain steps. During the procedure, you can fail in several steps. So it takes some experience, but also some, I would say, special conditions going to do. You might enter the leak and then you will not be able to cross the catheter. You have to develop loops. So it's a very, very complicated procedure, and it needs time also. And it's different between the aortic and the mitral, of course. Imaging is very important. We have here Michael, who is an expert, so he can confirm that. But excellent presentation otherwise.
Thank you.
I just want to comment one case that we had that had severe hemolysis in the mitral valve. We corrected it with one device. There was some residual, which we thought was okay, but the patient continued to have severe hemolysis. And we tried again from a different approach, but we were unable to close it completely. So that's, as you mentioned.
Hemolysis is an issue, and in almost 50% of the cases with paravalvular defects, there is 50% subclinical hemolysis. So we have always to be aware and be suspicious about that. Thanks for the comment. Yes.
Any comment from the audience? Final comment from the audience?
Congratulations on an excellent presentation. Supposedly, this is a mild to moderate paravalvular leak and the patient is relatively stable, no severe hemolysis. How would you suggest we follow these patients? Which modality? The echo, the TOE, CMR, volumetric criteria, and how often should we see them, especially as we said that sometimes deterioration might be some clinical? Thank you.
Thank you for your question. In case of not severely symptomatic with no congestive heart failure or no symptomatic hemolysis, then we go straight for the follow-up with echo. This is the first modality. And regarding hemolysis, we have to use the different laboratory parameters, like the haptoglobulin, the indirect bilirubin, and so on. So regarding the follow-up, that depends on the situation. Excuse me? That depends on the severity and if we are suspicious about that, yes. Imaging is important, especially CT can be very useful, and CMR as well.
Okay, thank you, Dr. Chalapas.
Thank
We
you.
have to proceed.